Next, we have paper 15, exogenous testosterone replacement therapy is associated with increased risk for arterial graft infections, presented by Dr. Longwolf and senior author Dr. Brook from Salt Lake City.
Good morning. My name is Ka'ohinani Longwolf. I'm with the senior fellow at the University of Utah. Thank you so much for the opportunity to present our data. We have no disclosures. Vascular graft infections are known to occur in up to 6% of arterial bypass procedures that involve prosthetic grafts, particularly those placed in the femoral location, and constitute a significant morbidity and mortality for these patients, including up to a 52% risk of limb loss and a 58% mortality at 1 year. Well, this is multifactorial. The bacterial contamination of prosthetic grafts at the time of surgery is the most common cause of these infections, and thus unsurprising that gram-positive cocci present in skin flora constitutes roughly 75% of the bacteria cultured from vascular grafts that become infected. There are many systemic patient-related factors that can impair wound healing and increase the risk of vascular graft infections. These, of course, include diabetes, obesity, tobacco abuse, vascular insufficiency, and malnutrition, among others. Based on recent urologic data, another systemic factor in men known to impair wound healing is both primary and secondary hypogonadism, leading to decreased circulating levels of testosterone. Testosterone is required for IGF-1 production, and therefore the decrease in IGF-1 can play a critical role in wound healing complications. So as such, we sought to evaluate whether low testosterone levels in hypogonadal men undergoing prosthetic graft prosthetic graft placements in vascular had an increased risk of vascular graft infections. We further hypothesized that if hypogonadal men do have an increased likelihood of incurring a vascular graft infection, testosterone replacement therapy might help to mitigate this risk factor. To test this hypothesis, we used the Truvian market scan database to identify 26,972 male patients over the age of 18 who underwent placement of prosthetic grafts in their peripheral circulation. After excluding patients who had undergone prior prosthetic bypass graft procedures, who had had less than 180 days of insurance coverage prior to surgery, 18,312 patients remained, of which 802, or 5%, were found to have a diagnosis of hypogonadism at the time of their bypass procedure. Among hypogonadal men, about a third were being prescribed testosterone replacement therapy at the time of surgery. And we also identified testosterone replacement therapy being used among a very small subset of non-hypogonadal men as well. So these are our total numbers. And as you can see in this slide, the patients who were non-hypogonadal who were receiving testosterone replacement was very low at an N of only 63. Over 80% of testosterone being prescribed in this cohort was being delivered via an intramuscular injection. After stratifying men based on whether they were hypogonadal and or on testosterone replacement therapy, our primary outcome was incidence of vascular graft infection. The association between hypogonadism and testosterone replacement therapy was analyzed using Kaplan-Meier curves and a Cox proportional hazard models, while controlling for potential confounding variables, including patient demographics, comorbidities, and the graft location. Characteristics of our study cohort are shown here, stratified by whether they are receiving testosterone replacement therapy at the time of surgery. As you can see, patients on testosterone were younger, more likely to be from the southern U.S., have a history of smoking, as well as diabetic. However, there was no difference in the types of prosthetic graft procedures being performed between our groups, including those involving both the upper and lower extremity. But then we looked at our primary outcome. There was a significant increase in graft infections among hypogonadal men receiving testosterone as compared to not being on testosterone. In addition, those were also higher than the control models of patients who were non-hypogonadal and not receiving testosterone. This finding was consistent for men undergoing both upper and lower extremity bypass procedures, but not surprisingly, the rate of vascular graft infections was much higher for those performed in the lower extremity, and therefore those having a groin incision. Next, we then looked at the incidence of vascular grafts over time among men stratified by whether they were classified as being hypogonadal and whether they were on testosterone replacement therapy or not. As you can see from the Kaplan-Meier curve, the men who were hypogonadal on testosterone, shown by the blue line, had a significantly lower freedom from graft infection. This increase in rate of infection appeared to be highest within the first year. However, it persisted after 5 years out from surgery. Of note, men who were hypogonadal but not on testosterone, which is shown by the red line, and those who are non-hypogonadal but on testosterone, shown by the purple line, these cohorts did not have a significant rate of vascular graft infection over long-term follow-up relative to control patients who had neither hypogonadism or testosterone exposure, as indicated by the black line. These findings were confirmed in our Cox proportional hazard model, which showed that hypogonadal men on testosterone were twofold more likely than non-hypogonadal men to develop a graft infection. After adjusting for patient age, procedure types, smoking, diabetes, and immunocompromised status, further, our model showed that lower extremity graft procedures were independently associated with a significantly higher hazard ratio for infections relative to grafts in the upper extremity, which is not surprising. In summary, our data shows that contrary to our working hypothesis, hypogonadal men receiving testosterone replacement therapy have a significantly increased risk for vascular graft infection. Infection risk appears to be highest in the first year among vascular grafts that involve the groin and lower extremity. There we go. So how do we explain these findings? Remember that low testosterone levels impair the body's response to wound healing, whereas exogenous testosterone levels can impede the immune response to bacterial infection, particularly of the skin. But in combination, they appear to act synergistically. This paradox might help to explain the greater susceptibility to vascular graft infections among hypogonadal men receiving high levels of testosterone replacement therapy. Based on these findings, there's still numerous additional investigations that need to be performed, but we concluded that we could consider temporary cessation of testosterone replacement therapy for men with hypogonadism who would be undergoing a vascular graft placement, particularly when using a prosthetic graft in the femoral artery location. Thank you.
Hi, Lizzie George from Stanford. Very nicely presented. Just two quick questions. One, hypoestrogenism in women has also been shown to have impaired wound healing. Do you have any idea from Truven market scan whether this effect was also true in women, or do you have any plans to look at it?
We have not looked at that yet. I think that's an excellent question, and looking at some of the basic science data as well as some of the recent neurologic data that comes out, estrogen actually and estrogen replacement may actually be beneficial in wound healing in these patients. But that was not included in our study.
Yeah, great point. Exogenous estrogen therapy has been shown to improve wound healing despite it being a steroid. And speaking of steroids, in your Cox regression, did you control for steroid usage as well? Because it looked like the immunocompromised group also had impaired wound healing.
Correct. So that we didn't have, based on the True Market Scan database, we didn't have full data to account for all of that. So we couldn't necessarily look at those who were receiving or the, all we could look at is the long-term exogenous steroid usage. And that was something that we were able to control for.
Thanks, nicely presented.
Thank you.